Building on what we covered in the Giddens safety concept, we remember that our competency for this is to be able to maintain a safe and effective care environment for our patients. And we can achieve this by following, national patient safety goals that was one of your assignments, homework before you came to class. What strategies you're gonna put in place so that you can ensure patient safety and quality. So our goal as nurses and as team members in the healthcare team is to really intentionally and intentionally engage in activities that will support patient safety and patient-centered safety rather. And so when we do that, we're trying to make sure that the environment is safe. We said we can't all the time prevent error, but at least reduce the risk for injury and prevent, all ill effects from prolonged hospitalization to disabilities, to even go where we want to go, that increased a sense of well-being for the patient. So we're doing that across our practice, and the institutions, according to the Agency for Healthcare Research and Quality, talked about the culture of safety and where the institution should be having that culture to minimize adverse event and make it impossible, make it harder, I should say, for healthcare providers to do the wrong act, and make it easier for them to do the right thing. And so, but anyways, we need the police and we need an oversight. So that's where the Joint Commission comes. And in box 27.1 in the textbook talks about those national patient safety goals. And your assignment was to look at those national patient safety goals. Your book says 2020. Let me hear it if they have another version. So that's what I need to see in your ticket to class. And what the Joint Commission does is it comes and audits the healthcare system, or the hospital says, okay, they meet the guidelines or they need to improve here or there. What the CMS does, and the CMS is your Centers for Medicare and Medicaid Services. So obviously you know that Medicare and Medicaid is the payer, the insurance for many Americans, especially those seniors, baby boomers. So what the CMS does is they rely on the report from the Joint Commission to say which hospitals meet those standards, and then they will renew their contract with CMS. So if you remember, QSIN, competencies and attributes, knowledge is the first rock we put in our solid foundation, and we need to be well informed about how does the environment safety play a role. And environmental safety is looked at from different angles. First, how are we maintaining our safety? Second, how are we maintaining patient safety? Next, we're looking how are we maintaining the patient safety across the continuum? So from the time they're in our custody and as inpatient to where they're gonna go home. So if we look at the patient human needs, you're seeing oxygen, nutrition, personal safety. So that's your Maslow's basic human needs. And then we see that we have vulnerable populations that are not able to get to those basic human needs. Sometimes it is just merely due to lack of access to care, and sometimes because these patients are on the other extreme of being, for example, homeless. So socioeconomic class, how is that going to impact meeting those basic human needs, and what vulnerability comes in terms of safety for those population. But then we said sufficient oxygen, basic human needs, and when the patient comes to the hospital, they're requiring supplemental oxygen, and then supplemental oxygen, because it's highly flammable, it's going to be, if it's exposed to a heat source, then the patient's going to have um, uh, risk for fire, and that's where fire safety um, comes in place. So you ensure that there's no exposed wires and that sort of activities in the hospital, because we are not going to worry about smoking, for example, in a hospital, because we're smoke free. But then when your patient goes on oxygen therapy home, you have to think about it. So that's the continuum we're talking about. CO poisoning is one thing where we're thinking about oxygen. Let's say your patient who's vulnerable and they're in a place where there's not proper ventilation, they're near a fireplace, these sort of things. Nutrition, when we talk about nutrition, we're thinking that we need to make sure that everybody has food on the table, but how safe is that food? Food handling, is the food refrigerated properly? Is the food stored properly? Is the food prepared properly? And when we think about temperature, of course, we're living in it now in the moment in Michigan here, exposure to any extremes of heat, whether hot or cold, is for prolonged period is gonna cause thermal burns, and so frostbite, hypothermia. And we talked about physical hazards when we talked about MVAs, poisonings, we talked about falls, and so that will carry over here. And so what can you do with MVAs or physical hazards? So you teach, for example, in infants and toddler, you're gonna teach about car seat safety. And we talked about older adults and how you maintain their environment free of clutter. Your book mentions that MVAs is higher among those specific age groups, and thus their safety is really high. Their safety risk for unsafe behavior is more in that higher in that group. But we talked about, the younger and the car seat and the older and the falls. More scientific knowledge base to bring forward is your knowledge of poison. How is it gonna impair health, or health, how dangerous it is, and it could be ingested, it could be inhaled, it could be injected, or knowing which group is more at risk for unintentional poison versus intentional poisoning. Falls, we talked about them, and just to highlight that um, their falls are major health problems. They rank second in leading causes of unintentional injury worldwide, and that's why you'll see the fall prevention initiatives are always front and center. Hospitals have to have those fall prevention, safety, fall and related injuries preventions to maintain their accreditation. Fire, and when we talk about fire, you need to be familiar with the basic fire measures, how we prevent fire and how we treat fire if it happens within our when we're working within healthcare system. So also, smoking, cooking, fire places, all these have been leading cause in fire-related injuries and deaths. And like I said, healthcare facilities are not exempt. Mostly nursing homes and mental health facilities, they have fire, been reporting fires, and so that's why you see all healthcare agencies indulge in routine fire drills. Disasters, natural disasters, floods, tsunamis, wildfires, tornadoes, all these are also reason to have and create unsafe environment. So you see also disaster drills happening all the time. Bioterrorism is another level of disasters that we look at and we are afraid of. And so you'll have that training as well. So um, you will dig deeper into disasters and preparation as you move along um, into the nursing program. We talked about infection control extensively, so you should be well versed with the transmission of pathogens, and that knowledge base is very secure for you. And so when we talk about pathogens, we're talking about microorganisms. And when we talk about pathogen, we're worried about those microorganisms that are pathogenic because they're capable of producing illness. And we talked about hand hygiene, how it's the most effective way of prevention of transmission. And here within the healthcare setting, we're talking about nosocomial infection, or what you know now as healthcare acquired infection or healthcare associated infection. These are the same terminology for talking about transmission of pathogens when the patient is under our care. And immunization, you know for sure that transmission of diseases, contagious diseases, have been, for the most part, many have been eradicated. If not, they were reduced due to the good job that we're doing for the general well-being of the human race with immunizations. And but we know, like, within your realm, you had to be vaccinated, and you have to have booster dose, or get vaccinated again for those certain viruses that we get exposed to. So that's your role of staying safe. Wearing your PPEs is your role in staying safe and keeping the people you're taking care of safe as well. So, for Mr. Gonzalez, I want you to think of what safety concerns you're anticipating, and let's discuss this in class. So this question is aiming at general safety teaching. And so you're teaching a young, inexperienced mother, and what do you need to intervene when they tell you what. So whenever they tell you need additional safety teaching, or what are you concerned about, it means that the person stated is inaccurate. And so obviously from the four options, B stands out, and that's why you chose B in here. So another layer of nursing knowledge base you need to have is knowledge about factors that influence patient safety. And what you're trying to do here is you're trying to prevent injury, correct? And we're going to talk about different preventions at different levels. But so first, what you're seeing is patient's developmental level and how we can prevent those injuries and maintain safety is based on our knowledge of patient's developmental level, based on our knowledge of mobility. We already covered that. Sensory and cognitive status, lifestyle choices, safety precautions, and so your applications of the making sure that the environment is safe and what factors impact patient safety based on those other elements is going to make you the prudent nurse that you want to be. So where the patient is at developmentally is gonna decide what you're thinking more is of a threat for their safety, and the infant, toddler, and preschool age groups is at a specific risks that are different than a school age child or adolescent or adult or adult. So infants, for example, you put their car seat in a rear facing position. So why we're doing that? Because of the risks inherent in that specific age group, the crib and how we need to maintain it safe, with being free of pillows, toys, or blankets because of suffocation hazards. As we move to toddlers and preschoolers, we're thinking more of avoiding foods that can cause choking. We're thinking more of toddlers and how they're going to be at risk of falling. We're thinking more of small food that they can put in their nose, and but also, peanuts allergies, and how they could not have been identified yet. And then we move to school age children, and here where we go into, bullying surfacing more with school age, physical, sexual abuse, psychosocial abuse, and there's in your book that box 27 too, about what risk factors increase violence, for example. You see nationally there is that move of reducing bullying, because how detrimental it is on the psychosocial and psychological well-being of the child and their ability to learn also, and how is it going to impact them throughout the life. And also you're moving into adolescent, and bullying stays in the age group as well, but then they inherit other elements that put them at risk: substance use, their self-worth, they have inherent risk factors, and your book states those on page 389 of why they're what is inherent in their age group as risk behavior. When you move into adulthood, we're thinking now, okay, there is still the risk of, substance use. There's still the risk of unsafe sex. There's still the risk of psychological problems, but you're more of and mental health problems. But more in adults, you're thinking now their lifestyle habits is gonna catch up with them. So drinking, smoking, drug use, stress, leading a high level of stress is gonna be impacting how the adult is what risks the adult is facing. And then when we go to older adults and the home of older adults, we talked about having the house free of clutter. We talk about also, the house having stairs and their comorbidities, and how that gonna affect their ability of staying free from risks, and being able to perform their activities of daily living. But then one thing that comes with age is that cognitive factor, and sensory perceptual factor. And so you think of dementia, and you think of Alzheimer, because these are more of a neurodegenerative diseases that are come with the older age, and they progress in the deterioration aspect of it, and so the patient's cognitive ability will decline. Those specific age groups have to have more vigilant interventions on the level of the family caregivers or the professional caregivers on that safety principles to make sure that those patients' living environments are safe, that your Alzheimer patients not wandering, and all those safety checks that you put in place. And you're seeing how we moved from the car seat to the wandering older adults. So that's how you put in your mind, different risks are inherent in different developmental stages. And then we come to individual risk factors and how each person leads their life will increase their safety risk or reduce those. So we talked about these when we talk about influence of chemical substances, drugs or alcohol, the job we do, the sports we play. Then we talked about impaired mobility and the safety risks, muscle weakness, gait, coordination, balance, neuromuscular conditions. And then we talked also about cognitive impairment and patients with dementia, but also patients with depression, with the psychiatric disorders, patients with the delirium that's superimposed on their dementia or psychiatric or mental health illnesses. Also impaired memory, such as what you see in Alzheimer. Economic resources is going to be another layer of safety inherent in it, like the homeless, So put that in addition to the person being depressed or having substance use problems, and that expansion puts the risk for injury exponential. And then there's the fact that some patients are unaware of safety issues at their home, like not knowing where to keep the medicine because the children can get to it, or poisons such as your household cleaning agents, and or merely eating something that is expired. So with this second part of the case study, what environmental hazards should Joni be assessing? So we'll wait for the answer in the classroom. Risks in the healthcare agency. Oh, and it is built in. And unfortunately, yeah, we think we're a place where it's going to be safe. We're going to see if we saw with the, for example, medical errors that it's not as safe as we thought it is. And so we work our best and we try hard to prevent those medical errors, but they continue to happen. And it is a challenge. So when they look for root cause analysis of why these medical errors continue to happen, like I said, they earlier, they found that communication is an error, and communication and miscommunication or lack of communication or fear of communication. So for example, the Joint Commission, in addition to CMS, they wanted to prevent those errors and keep that safety. So they did that campaign of Speak Up, and where they're encouraging patients, be part of your safety and speak up if your nurse comes in and doesn't wash their hands, or your doctor provider comes in and doesn't wash their hands. So also for the junior healthcare team to speak up against that power healthcare team, like that, a nurse that's new graduate and attending that's trying to be belligerent, but there is encouragement to speak up on that behalf. And so we'll talk in more about the costs, and cost is I'm concerned, I'm uncomfortable, this is a safety issue, so you costs only when it's appropriate. We'll talk about that more. And so you'll see now we're being introduced to another national organization, the National Quality Forum, which is a lead on the national collaboration among healthcare agencies to improve health and healthcare quality by measuring those. And so the box 27.3 talks about those measures and what are what events that happen in the healthcare system are serious and they should be reported. But like you report everything, but these are mandated and they're considered never events. So they shouldn't happen. For example, if the surgery was performed on the wrong side. So you'll see that box 27.3 explore those elements. And actually the CMS considered those never events. Those serious reportable events, CMS considered them never events. And so you see CMS talks about those and other elements in box 27.4. I want to highlight what does present on admission indicator mean, and you need to know this. And one example would be you admitting a patient into your unit and you miss to check their behind and their skin. You just assess them from the front and they already come with a pressure injury or pressure ulcer. They have a wound on their back. You miss that. And when the patient is there for 2 days and now you find it, how can you prove that it was present on admission? So what does present on admission mean? It means if something was present on admission, such as a pressure injury or the patient had a UTI before they came to you, you can bill for that because you're going to care for it and help the patient heal. But if you don't document that it was present on admission, what is assumed is that the patient acquired it from the hospital. And now it's a healthcare associated or healthcare acquired event. And now the CMS is not going to pay for that in a sense. That's where we're that's what we are highlighting. So then we talk about environmental risks and then chemical exposure. So when we talk about chemicals that are found around in the healthcare, let's talk about chemotherapy, for example. So you're going to be exposed and the patient is exposed for chemotherapy, but your patient's benefiting from that, although they're having the side effect. But if the nurse gets exposed to those because they did not maintain their safety mechanisms in place. Same like how you put the PPEs to prevent the spread of infection and to prevent it from coming to you when you put the gloves when you're exposed to the blood and fluid of the patient. Similarly, you need to maintain your precautions when you're dealing with chemotherapy. Continuing on the risks in the healthcare agency, we have discussed falls and your book in box 27.5, page 39.2 discusses evidence-based practice fall prevention and introduces you to the PICOT question also. So it would be an interesting read for you, teaching you how do we even start the research process. And we started always with a PICOT question. Does a multifactorial fall intervention program compared to one intervention reduce incidence of falls among hospitalized adult patients? So you're having your intervention is that multifactorial fall prevention program, and that is you're doing more than one thing to prevent the falls versus doing one thing only. And what is the outcome is how many falls, incidence of falls is how many falls, among who's your population? It's your hospitalized adult patients. So other than that, you're going to have patients that come with inherent risk for accident. So like other than falls, we're not talking about falls. For example, people who come with suicide, certain age group when they're unintentional ingestion or intentional ingestion or injection of, overdose with substance, drug, illicit drugs, and and setting fires or so these are things that come inherent. In addition, you have patients that come to you with seizure disorder. These are patients that are going to be placed on seizure precaution, so you have to know this. Versus your patient is going to be put on suicidal precautions. There are other inherent risks with certain procedures, and there are certain procedures that are built in with if performed inaccurately, that they're going to be causing harm. For example, when you insert a urinary catheter, or when you put an IV, or when you do the dressing without maintaining surgical asepsis. These are some of the related procedure related accidents. And then you have equipment related accidents. So for example, if the element malfunction, or you misuse the equipment, and so that is one element. For example, electrical cords are not checked for their exposure. They can be electrical hazards, and they can cause electrical fires. When we talk about workplace safety, there's more than one conversation we can have, and bullying is one place where you're thinking, okay, being that microaggression, versus being at risk because you're a nurse and you're exposed to these patients that are going to be coming and they're cognitively impaired, and so verbal abuse, physical assault is another layer of workplace safety or unsafety. It's built within the job. This is a high risk job. When we think of the nursing process and safety, you've just been exposed to how much background information you need to bring forward to understand what all the safety risks that are present. So you can appreciate that knowledge is going to be key in the formula. Okay, you know that is essential. So when you go to your box, what is it's figure 27.2, and here it is. It's in your book. So you see knowledge, and then knowledge, and under it you're seeing basic human needs. You're saying what all the potential risks that we talked about, developmental stages, illnesses, medications, and all this. And then your experience. And so how much personal experience you have, how much experience in being in a clinical setting. And then that is going to feed into your ability to assess your patient. Another thing that adds to that critical thinking is the standards. Do you know the standards? Do you know ANA standards for nursing practice? Do you know your agency's standards for fall precautions, for seizure precautions, for suicide precautions, also restraint protocols? We'll talk about this. And are you familiar with patient safety goals? And then your attitude. Can you be responsible enough to collect unbiased, accurate data and report those? So you'll have that conversation when you talk, okay, what if you suspect that your patient is being subject to child abuse or sex abuse or adult abuse, So you start the nursing process always with the assessment, and always we're looking through the eyes of the patient. And when we say we're looking through the eyes of the patient, we're listening to the patient. We're listening to what the patient is saying, their problem, because we are going to deliver patient-centered care. So if we're delivering patient-centered care, we need to do needs assessment on that patient. What do they perceive as risk factors? What are they most concerned about? What do they know about those safety risks? And what have they done to prevent those risks or to deal with these risks before they came to our care. And in that you see box 27.6 gives you some verbiage and some questions that you can ask your patient on the level of activity exercise, and that pertains to your falls and injury risk, what medications, falls history, how their home is maintained, and safety in that respect. And continuing with the nursing history and examination, we need to understand that medical history, risk factors, for example, for falls, underlying conditions, all pose threats to safety. So then you go ahead and do the physical assessment, and how is that affecting the patient's mobility, for example. And then make sure when your patient is in your custody that you're also assessing their environment when they're in your custody. Is there any hazard in their immediate care environment? Clutter can exist in the hospital, same like how it exists in the home setting. You're assessing the risk for fall, and we talked about that, where you're assessing whether you're preventing any medical errors, and that's by you making sure that you are doing those proper abiding by the National Patient Safety Goals. Remember, so National Patient Safety Goal 1 is proper patient identification. So how do you do that? You ask the name and date of birth. And you ask the patient to state those while you're looking at their ID badge. Sometimes if the patient is confused, you look at the medical record. You never use the room number as a form of patient ID. And these are some of the stuff that you're doing to prevent those risks for medical errors. And we talked about disasters and how you have to be always prepared when whether it's a national disaster or community disaster, and they'll do those drills. When we thinking about patient's environment, we said there are home hazards that are specific to that patient. So we think of those, and we talk about them same, like not same as you're thinking within your healthcare environment, but in home, for example, patient is going to be preparing food. Are they able to recognize how to prepare the food, how to handle the food, how to store the food? Do they know, for example, the oxygen safety, if they are on oxygen, that they can't smoke near that? Do they have lead poisoning probability? And then your nursing diagnosis for safety, all these are safety geared nursing diagnosis. So risk for fall is one of the things we're working on now. Risk for injury is can be also with those patients' risk for fall. In box 27.7, for example, they talk to you about what are the, how do you go about the process of assessing whether your patient is at risk for fall. So that's good to look at. Next step is planning, and planning in the nursing process is of essence. Again, you're using the same tool of knowledge, experience, standards, and attitudes before you do the planning. Again, assessment was done through the eyes of the patient. Now you're doing the planning with the patient, because nothing about me without me. And then we talk about planning, we need to talk about those goals and outcomes. They always have to be smart, and we'll talk about that when we go to the nursing process lectures, and we'll talk about how do we set priorities. We talked already about team and collaboration. Of course, you need to go in and read about those. Your book has a very nice concept map about risk for falls, including all these elements in figure 27.4. It's a nice concept map. Please make sure you read your book. So this presentation is not by all means extensive, and so you need to refer back to these elements when they tell you how do we prioritize in the case of safety, how do we set priorities. You have to read in your book and be very well informed around those strategies. How do we prioritize? Of course, I don't want to dwell too much before I cover the nursing process chapter, and which is going to come in 2 weeks. When we talk about teamwork and collaboration and we're developing a care plan, one of your team members is that patient and their family. So, and we never skip any of those patients. You have another care plan in your book, and that is on page 397. It's also another perspective. So between concept map and care plan, there's not much difference. And so this was what you always think of these 4 pillars before you start into any actionable part of the nursing process. When we go to the implementation, we're gonna have to make sure that we have the skills. That's implementation is psychomotor, so we make sure that we have the skills. So knowledge, we know the Morse fall scale. Now we're doing the implementation on the patient, and so we're making sure that when we get them up from bed, that we're using appropriate tools that are gonna keep the patient safe, and we're preventing injuries while we're doing something that we're trying to help the patient. So for example, when we're coming to position a patient, setting them up, and we know that they have orthostatic hypotension. This is a patient that's going to be at high risk for fall. So in addition to us intervening in making sure that we ask them to dangle their feet first and then get up and take a few minutes before they get up and just take a deep breath, look straight ahead of them. And we're also teaching them about those strategies for future. Also, for example, if we're thinking of the patient that's going to be at risk for fall, because and we know that they're going to be needing to use the bathroom. So what we do whenever we come to the patient, we do rounding every 1 hour, every 2 hours probably at night. We're asking the patient, do they need to go to the bathroom? Because we don't want them to run to the bathroom when they gotta go. And we make sure that they have those non-skid socks on. And at the same time, when we're doing health promotion, we're teaching these, whatever we're doing, we're communicating to the patient so that when they're on their own, they perform these safe behaviors. So the next few slides are focusing on the risk for falls prevention. So you have this algorithm kind of guides you. If patient meets criteria 1, then you go to criteria 2. If they meet criteria 3, then you go to criteria 7. If they don't meet criteria 3, then you go to criteria 4. And so you have an algorithm that you can apply in multiple situations. And the goal is to be able to meet the needs of all your patients. You have multiple boxes, 2710, 2711, 2712 in your textbooks. These dwell on, prevention of electrical hazards, use of fire extinguisher in the home, and intervening in accidental poisoning. These are required readings that we need to read and make sure that we are able to apply that knowledge. I remember when we talked about fall prevention, we talked about following those protocol and it being patient-centered. And patient-centered means that it was about the patient, with the patient, for the patient. So where we individualize the care and we ask the patient to be part of it. And the use of assistive aids we already discussed. Now, another element that is very essential when it comes to safety is the use of restraints. We understand that the patient is who is confused or agitated, they're going to try to remove their IVs, they're going to try to remove their Foley catheter, they're going to try to rip things apart, and so for their safety we may be needing to temporarily restrain them so that we can keep them safe. And so you'll get to know that there are physical restraints, there are chemical restraints, and then we learn all these essential or needed interventions, but we need to know that restraints are not a solution to a patient problem. They're a temporary fix. And we need to, and we're doing that temporary fix to provide safety for the patient, not for our comfort. So we need to fix the problem. Why is the patient confused? And so you'll see in box 2713, they give you all those alternatives to restraints. And you have to understand what the side rail mean. 4 side rails up is a restraint, and so your patient is under, for that matter, is considered restraint. And why they want to be so stringent of the use of restraint? Because serious complications happens because of restraints. Not only the fact that the patient is going to develop pressure injuries because now they're less mobile, they're going to have all the consequences of immobility that you covered and you filled in that form, pneumonia, constipation, but they're also going to have low self-esteem, they're going to feel humiliated, and it's going to add up to their confusion and their agitation. So and some patients have died while they're in strain, and that's a big never event, and CMS will investigate that. And also you need to use other methods. And so when we talk about alternative, you see electronic bed and chair alarms. These are used in very extensively in the hospital to try to prevent use of restraints. And you have to know that there are legal consequences, and you have to follow the agency specific policy procedure on how to use the restraints and how often do you monitor the restraints. And of course, to use them, they have to be clinically justified. So to say that I'm clinically justified, there has to be an order from a healthcare provider, whether it's a PA, nurse practitioner, or a primary doctor, care physician, and they need to have face-to-face assess that patient, and they need to sign that. And the order has to be current. When we talk about current, there are 2 orders. There's 2 types of restraints. There is the violent and non-violent. And so the non-violent order is within 24 hours. The violent, it's 4 hours only. And so when they write the order, they have to state the type and specify the duration and why is it. For example, the patient is removing medical devices. And so restraints, for example, cannot be a PRN order. And of course, it's our responsibility to do the continued assessment. Other layers of safety, we see box 2714, they talk about fire prevention guidelines. So they talk about trace, and you have to know this mnemonic and what R and A and C and E stand for, and be able to use it also when you go to the to work as a nurse, they'll train you of how to use them, but you need to at least know those mnemonics and what do they stand for. We talked about electric hazards. Also, on fires in image 27.8, it shows you how the correct use of the fire extinguisher. I want to highlight the seizures, and you'll have patients who have those neurological injuries or because they have some metabolic disturbances and they'll have seizures. So don't get stuck on the term. We are not asking you questions of what caused the seizure and what type of seizure and what medications. We just need to know that you know that if your patient comes and they have a history of seizure, that you are able to pick up on that seizure and that you were able to put the seizure precautions in place. And so box 2715 talks about the tips for protecting patients during a seizure, and you have to know this. Okay, your patient who starts with a seizure may end up with status epilepticus, which is prolonged or repeated seizures, and that's a medical emergency. So you don't leave the patient who has seizure alone. That's also knowledge you have to know about, basic knowledge about seizures. Again, we're not discussing seizures as a medical condition. We're discussing just the precautions, how to pick up on one. It's usually the patient will show tonic-clonic activities, and they last for approximately 2 minutes, and patient may lose consciousness. So you need to have actions in place that will keep the patient safe. So what do? You pad those side rails. You make sure there is a suction. You make sure that there's oxygen ready, and that you don't leave them alone. They talk about disaster, and we talked about this during previous slides. But just know that when you're a hospital or your institution goes into a disaster mode, you'll be assigned roles, and so you will be also trained on that. Workplace violence prevention is something that sometimes you can't prevent it, but you just have to know that you will be at risk. Your patient's at risk for that, so be able to assess that patient and see what is their cognitive level, what is their comfort. Are we meeting those? Are we using restraints when we shouldn't be? Are we able to redirect the patient and coach them, use those communication therapy, therapeutic communication words? And so they have at the end on page 408 in your book on how do you deal with the patient that's in a violent situation, just some tips to follow to reduce the violent behavior. And then at the end, we start with the beginning in mind. We always see and evaluate things through the patient's eyes. We ask the patient what was their opinion, were they feeling unsafe? Now we're going to ask them, do they feel safer because of what we did? Okay, and how could we do it better? And so we're always evaluating, because we will always want to do meet and keep meeting those expectations of the patient and their family. And so your evaluation is another follows the same method where our knowledge, experience, standards, and attitudes will depict what we are evaluating. But always when you're evaluating whether you met those expected outcomes that you set for yourself. You have to stick to those outcomes and measure them during your evaluation. Last, our safety guidelines for nursing skills is just a review of what we are expected. There is a nice depiction on page 409 about what is our role as professional nurses, what we do to ensure patient safety, and what are some of the skills that we need to understand and implement, including, how we delegate, what do we delegate, how do we collaborate, and the equipments we use as safety tools. So page 409 and the skill number 27.1 is a detailed assignment of how do you go about, preventing falls, and in addition to other elements of mobility, for example, use of assistive device. And then skill 27.2 is again touching upon physical restraints and what do you delegate and what you don't delegate and how do you collaborate. And again, you have it step by step in up to pages 415. These are things that you have to know and you have to read. And I know there's so much reading, but to be an effective nurse, we have to be at the base, and the base of a nurse, average nurse, is a safe, prudent nurse. The remaining slides are more of quiz questions, so you can go over those. I will, if you have any questions about how the case study continues, we'll go over that in class. Thank you so much for your attention, and I'll see you soon.